Ensuring Water Safety, a comprehensive guide to water testing in dental practices. I'm Dr. Kroling. I'm the Chief Education Officer here at Dental CE Academy. I am a public health dentist here in Phoenix, Arizona. I was the chief for the Office of Oral Health for Maricopa County's Public Health Department. And I teach a lot of courses on infection control here. So you may have joined us before. This evening, we're launching a new course on water safety, waterline safety, and testing as well. I do want to thank ExactBlue Technologies for supporting this program this evening. And following my presentation, April Smith with ExactBlue Technologies will be talking to you about their testing. So please stay on for a few minutes afterwards, and she's going to be talking about in-office testing and the benefits so that you can get immediate results and know that your practice is safe. Your water lines are safe to use. All right, so my presentation will be 1 hour from 5 to 6. And at 6 o'clock, April will be joining us. She's a leading expert and educator in waterline testing and waterline safety. She's also a public health nerd like me, so it's great to have both of us here this evening. We'll also be joined by George Bodos, who is the co-founder of ExactBlue Technologies. He's a chemical engineer, and he is also a leading expert in testing. So two great folks joining us at the end of my presentation. To receive continuing education, you can log off after the presentation. You'll be redirected to the quiz. The promotional portion is not required for CE credit, but I do hope you'll stay on because it's a major part of what we're talking to you about this evening. You'll need to finish that quiz by May the 13th. It's 7 days to complete. You have unlimited attempts and minimum passing score is 80%. All right, my conflict of an interest and financial disclosure is there for you. Learning objectives this evening: understand the importance of water quality monitoring in dental practices, describe sources of water contamination. We'll discuss regulatory requirements and guidelines, compare types of water testing, and implement water management protocols. I'm starting this presentation with a photo of a raccoon, and you all are probably saying, my gosh, what happened to Dr. Kroling? She's losing it from teaching so many classes now. But I get excited about infection control because there's so much of it we have in our purview that, and there's so much technology out there to really help us. When I first started in dentistry as a registered dental assistant in 1981, we didn't wear PPE, right? Our bare hands went into bloody mouths. We, really, to my knowledge, I never disinfected a surface, right? I used a 2x2 gauze, maybe an alcohol. And how did we take care of our hand pieces at that time? 2x2 and alcohol, and blew some lubricant through it, and we were done, right? What about water testing then? Well, the majority of practices then, in fact, I think all of them, relied on municipal water source. And I never treated a water line the entire time I was a dental assistant. We never tested water lines, none of it. Now, the raccoon, getting back to the raccoon here. So as a dentist, I was in private practice and I was also in public health practice. And in public health practice, I was hired by the government in public health to work for a Native American rancheria. It was very remote. It was up in the Sierra Nevada mountains, beautiful area. And I was there for several months, and we received a boil water advisory alert, right? Now, this was a little town. I don't even think we topped 1,000 people, but we were a hub for medical care because many of the folks around that area had to travel 3 or 4 hours just to get to us through the wilderness. And if the weather was bad, it was worse. So boil water advisory alert. Why? Because we had a raccoon that fell into our water source. Our water source for the entire municipality was a well. And that raccoon didn't survive the experience, decomposed in the well, and we had to shut down. And that was my first experience with water safety, water line safety. What were we going to do? We couldn't see patients. We were it. It was a medical center and a dental clinic at this rancheria. I went to the supervisor and I said, what about ordering some water, bottled water systems for the units that we had? Because at that time we were just using the municipal water source. We called some distributors and they said, well, we're not going to be able to get those up there because it was winter, but we might be able to fly them into the local airport, one strip airport, if you can pick them up, but we're not sure we can get anybody to install them. So I talked to the supervisor again and I said, well, the best we can do is to see if we can get them here and install them ourselves. So that's what we did. They flew them into the airstrip and we picked them up and we installed them. Now, this was the exact area where we were practicing. So this was pretty remote. In fact, where I lived was to the right side of this river. This is the Feather River Canyon. I lived on 90 acres in the wilderness, and our water came out of a spring-fed stream, filtered through sand into this wooden cistern, and it was tested every day by the state, and they would dump bleach into it. So again, very remote. The dental clinic, we were able to get those water units installed, but we received very little guidance. I mean, we also changed out some of the water lines, not all of them. We didn't test them, can tell you that, because we had no guidance. So that was my first journey into the water line foray of my public health career. So let's talk about the importance of all of this, aside from raccoons falling into wells. Well, why are we here today? We're here because we're concerned about infection control, patient safety, staff safety, regulatory compliance, risk management, and professional responsibility. The problem here, and this is a quote, the water that leaves these water lines in our dental units, also called dental unit water lines, may expose patients through the contact with mucosa, skin, bone, normally sterile tissue, vascular tissue, contact during dental care. So when we provide procedures, we may create a wound or they may walk in with a wound. We manage chronic wounds all the time when we're treating periodontal disease, actually, by ingestion, so by swallowing the water, and also due to aerosol, by inhalation, right? So our procedures are aerosol generating procedures. Just about every procedure that we perform in the dental practice generates aerosol, even our exams, because we're using the air water syringe. And that air water syringe is connected to a water line, right? So aerosol is a problem. Ultrasonic scalers, also a problem, as well as our high-speed air handpieces. Okay, so infection control. Dental water lines can harbor biofilm. They can also contain planktonic bacteria. Those are the bacteria doing the backstroke. They're freewheeling it within the lines, but the biofilm is attached to something. In periodontal disease, it can be attached to the root surface, the periodontium. Here we're talking about bacteria in a community. It forms sort of this protective slime community here to protect itself from what? Antibiotics, anything that's going to kill it, disinfectants. if they're anaerobic, etc. So it's a slimy layer that accumulates over time within the dental unit water lines. And if we don't treat the water lines, it can lead to contamination of our water supply, and that can increase the risk of transmission to our patients. So regular monitoring, maintenance of our water helps to prevent the buildup of biofilm and mitigate the risk of cross-contamination. So I always refer to this diagram, and if you've taken my courses in infection control, you know the chain of infection is a big deal to me. And the chain of infection, this is made of links, right? So if you think of a chain around your neck, the way that chain stays on and does its job is those links have to be intact. So we want to disrupt one or more of these links to prevent transmission of disease. And it starts with a pathogen. So bacteria, virus, fungus, parasites, those pathogens need a reservoir. Today we're talking about water as the reservoir. Portal of exit, a way for that pathogen to escape its reservoir, and a mode of transmission. Now, normally in healthcare settings, hands are the #1 mode of transmission. So we talk here about direct contact, indirect contact, and then vectors, which we're not going to get into today. But we're talking today about how does water in our water lines, in our dental units, contaminate potentially our practice, make us sick or make our patients sick. Portal of entry, either through the mouth, nose, eyes, or cuts in the skin. And then we need a susceptible host. We need someone who does not have antibodies against a particular disease or infection caused by this pathogen. And that could be really anyone, but we know we have patients that are in populations that are greater risk, right? Our older adults. The immune system is not as stealth as it was when we were 23. And so we're at greater risk for morbidity and mortality as we get older, if we come into contact with infection. So in our dental practices, we have the responsibility to protect all of our patients and understand that we do have these populations at greater risks. We have to do everything we possibly can to protect everyone. Infants, of course, because their immune systems are not mature, and then our patients that are immunocompromised. So those patients who may be taking medications for Crohn's disease, rheumatoid arthritis, maybe cancer treatment, HIV, AIDS, and so forth. So all of these links have to stay intact for disease to be transmitted. So we're trying to disrupt one or more of these links. And today we're going to talk about water. How can we treat and monitor our water to prevent infection? All right, these are the CDC guidelines. And one of the things to note here, using water of uncertain microbiological quality is inconsistent with infection prevention and control principles. Why is that at the top of my list? I'm going to tell you why, because I teach different courses again on infection control. And from time to time, I will have a clinician say to me, well, Dr. Kroling, are there any studies that prove that a patient got MRSA or became infected with MRSA from a dental operatory? Well, we have a couple from years ago, but that's about it. Is that a reason not to perform our due diligence in infection control? No, right? Because the absence of evidence is not evidence of absence. We know that if we are using contaminated water, it is inconsistent with our practice to do no harm, right? Another example I have is hand hygiene. We use containers, many of us that we're refilling, etc. Those have been shown to create more cross-contamination with fecal bacteria, for instance, viruses. Question I always get asked is, well, do we have proof it ever came from a dental operatory? No. Why is that? Because dental practices are outpatient settings, first of all. And in an outpatient setting, surveillance is poor with these sorts of transmission. If you are in a hospital and you become sick in the hospital, what we call a nosocomial infection, or you were discharged and you became ill maybe a couple days later, those can be easily tracked. And hospitals are fined. Physicians are fined. Dental practices haven't been fined yet, but things are changing on that end. They're starting to use, for instance, codes in pharmacies. If a patient was prescribed an antibiotic, for instance, and they go back for more medicine to treat C. difficile, chances are, if that antibiotic was prescribed by a dentist, in the future, that dentist may be fined if they are found to have prescribed inappropriately or their practice was contaminated. So, in terms of water maintenance, water monitoring, if we believe that it's low risk and we're not performing it, it is inconsistent with our infection prevention and control practices again, as well as just ethically inconsistent. Levels of contamination in water from untreated systems can exceed 1 million colony-forming units per mil, and untreated dental units cannot reliably produce water that meets drinking water standards. And the EPA's standards are what? Less than or equal to 500 colony-forming units per mil of heterotrophic water bacteria. Even using source water that contains less than or equal to 500 CFUs per mil, such as tap distilled or sterile water in a self-contained system, will not eliminate bacterial contamination in treatment water if biofilms in the water systems are not controlled, right? So if you're not treating the water and you're not testing the water, you're again putting your patients at risk and you're putting yourself and your staff at risk. So removal or inactivation of dental waterline biofilms requires the use of chemical germicides. Why is monitoring water quality important? Again, patient and staff safety. So dental procedures that involve the use of water for irrigation, rinsing, and cooling. Contaminated water exposes us and our patients to pathogens leading to infections or other health complications. HAIs are healthcare-associated infection. Contaminated water can also contribute to aerosol production during their dental procedures. So your ultrasonic scaler, again, high-speed handpiece, three-way air water syringe, if it's hooked up to a water line that's contaminated and you are performing an aerosol generating procedure, which you are, you're generating even more pathogenic aerosol and you're breathing it. And we're going to talk about ultrafine particles. Monitoring water quality helps ensure that the water used during dental procedures meets the safety standards and will safeguard patient health as well as yours, because your exposure is an occupational exposure and it's cumulative. All right, what are some of the pathogens of concern? These are the three top. Now, you're going to see April's presentation after mine, and she's going to list quite a few. She's the expert here, she and George, and she's going to show you how they're testing tests for several pathogens. But we're going to talk today about Legionella, Legionella pneumophilus, Pseudomonas aeruginosa, and non-tuberculosis mycobacteria. All right, Legionella is a bacteria. It's a gram-negative rod. Its source is often from drinking water, called potable water, and it's transmitted usually through aerosol, right? You've heard of Legionella outbreaks. We'll talk about a couple here. Healthcare workers, including dental clinicians that come into contact with aerosol, are at greater risk. So let's talk about some of the diseases transmitted by these bacteria. Legionellosis atypical pneumonia, that includes Legionnaire's disease. Pontiac disease, which is a less acute form, transmission via inhalation of aerosol. Okay, and then healthcare workers including dental clinicians, are at greater risk, and there's a citation for you. This was a study here, Legionella pneumophila, presence in dental unit water lines, a cultural molecular investigation. This was in the West Bank, Palestine. And this was a study to determine the prevalence of Legionella in water and biofilm samples from both tap and dental unit water lines collected from 5 sites of dental clinics and faculties across the West Bank. And the results showed that the dental unit water lines of the examined dental clinics and faculties were contaminated with Legionella pneumophila. Their findings revealed a serious potential health risk for infection of immunocompromised patients and dentists post-exposure. This was a woman who died after contracting Legionnaire's disease from a dentist's office. There's the link. And there were some questions around that particular case. There were questions about was Legionnaire's maybe, or Legionella, excuse me, introduced during the installation, etc. But you can look at the study. So when we're talking again about dental unit water lines, which are very small in diameter, you'll have bacteria that can be the planktonic bacteria. Again, they're just moving around freely. These are example of Legionella, and then Legionella in the biofilm and with other bacteria. So it's a community there. They're formed up within this sort of slimy protein type matrix to help protect them from disinfectants, antibiotics, and so forth. It's a community to safeguard their assault by others that want to kill them. Now, when the bacteria, as they get deeper into that biofilm, they're often anaerobic, right? It's very difficult to get rid of biofilm. So you want to try to prevent it from ever happening to begin with, and that's nearly impossible. So it takes an ongoing organized effort, serious effort to keep it at bay. Sometimes the biofilm will break off in pieces and get, ejected through the water line and so forth. Initial waterline contamination by Pseudomonas aeruginosa in a newly installed dental chair. And another link here. And oftentimes that it can occur through the patient as a source, backflow, right? So we'll talk about that shortly as well. And then I'm sure many of you have heard of, in the recent history, outbreak of invasive non-tuberculous mycobacterium infections that were associated with a pediatric dental practice. And these were a series of clinics in Southern California. And this was considered to be the largest outbreak of invasive infections attributed to NTM seen associated with this particular chain of pediatric practices. Of 1,089 patients at risk, there were 71 cases, 31% confirmed and 69% probable, identified as of March 19th, 2018. The median age was 6 years, the range 2 to 11 years. The symptoms began at a median of 85 days. So the range was 1 to 409 days. So imagine going to this clinic as a 6-year-old and 409 days later, when you're 7, you develop this infection because you were exposed in this practice. And this was following primarily pulpotomies. Pain or swelling on admission reported in 79% of the cases. 21% were asymptomatic. CT findings included 49 with abnormalities of the mandible or maxilla, 13 with lymphadenopathy, and 19 with pulmonary nodules. 70 of the 71 cases were hospitalized, and they underwent surgical Debridement for an average of 8.5 inpatient days. The range was 1 to 60 days. 23 had greater than one hospitalization. 26 required inpatient surgery, more than one inpatient surgery. Permanent teeth were lost in 45 out of 65 of these cases. The range, 1 to 6 permanent teeth. Intravenous antibiotics were administered to 32 cases for a median length of 137 days. It was 113 to 282 days. And these were all children. Why? Because the water lines were not treated. And there's a link to one of the stories here and one of the children that were hospitalized and had portion of the mandible removed as well as permanent teeth. Okay. If anybody has any questions, please type them into the chat area for me. For those of you that may have joined a little bit late, be sure that you have the handout and CE credit instructions. Tap on that red banner at the top of the screen, or you can check your email. It was sent to all attendees about an hour ago. I'm sorry, registrants about an hour ago. All right, when we're talking about the importance of monitoring our water lines and water quality in the dental practice, we did mention aerosol. So aerosol deserves a little bit more attention. This is a course that I also present for an hour, so you're getting the cliff notes this evening. But we know that aerosols produced by ultrasonic scalers, handpieces, three-way air water syringes can emit spatter, droplets, droplet nuclei, and ultrafine particles, right? So ultrasonic scalers, handpieces, air water syringes are all connected to your water lines. And if you are not treating your water lines and you are not testing and monitoring your water lines, you can be contributing to even more pathogenic aerosol. And it can affect the patient as well as you. And again, your exposure as an occupational exposure is cumulative. And I'm here to give you some information today that may have you rethink aerosol and how to approach your water testing in a much more serious way if you haven't prior to today. Because these particles that are formed, the spatter, which are the large particle sizes over 50 microns, they'll behave like ballistics. They're going to bounce around in your dental practice. They contain pathogens. Eventually, gravity will bring them back down to earth. Either they land on your countertop or your patient tray, in your hair, your forearm, etc. The droplets and the droplet nuclei can be less than 50 microns, oftentimes as small as 2.5 microns. So the droplets and the droplet nuclei are very light in mass. So they can float around in your dental practice for hours because of that. They don't just stay in the operatory. They're going to travel out the hallway. They can be re-aerosolized just by walking past a contaminated surface or your HVAC turns on. The droplet nuclei are evaporated droplets, so they're highly condensed for pathogenic material. And the ultrafine particles that I want to really emphasize this evening, the PM1s can be less than 1 micron. And the smaller in size these particles are in diameter, and the lighter mass they are, they can preferentially embed in the respiratory tract, even to the level of the alveoli. And when that occurs, if they are small enough in diameter, these ultrafine particles can enter the bloodstream and they can translocate to other organs in the body, the brain, the lungs, etc. And there's a study there for you, but these ultrafine particles are thought to contribute possibly to Alzheimer's, certainly respiratory disease, and more. So we have to really rethink our aerosol as well as our water treatment, water testing, and monitoring. Dental procedures, wound management, of course, dental procedures can create portals of entry, as we saw in the chain of infection, for these pathogens to enter that are introduced from contaminated water lines. Patients may have existing oral diseases already, and periodontal infection, periapical abscess caries in the case of those children. If they were having pulpotomies, they probably had some abscesses going on, right, or very deep decay. So those were open wounds. It's important to monitor our water quality also because of regulatory compliance. We're required to, in many settings, the Centers for Disease Control and Prevention, the Environmental Protection Agency have established guidelines and standards for water quality in dental practices. Compliance is essential so we can ensure the safety and well-being of ourselves, our patients, our staff. And regular water quality monitoring helps dental practices adhere to regulatory requirements and maintain their compliance. And then risk management. Dental practices can proactively identify and address potential risks associated with water contamination, especially if we're testing regularly. So testing, treating, and preventive maintenance protocols. Proactive risk management minimizes the likelihood of water-related incidents and helps maintain the practice's reputation and credibility. Imagine if you had sent 70 out of 71 children to the hospital because you weren't treating and monitoring your water lines. And in that case, I believe, and this isn't fear-mongering, this is just factual, there were about 220 lawsuits that occurred from that one incident. Okay. And of course, our own professional responsibility here. We have a professional duty to prioritize patient safety and well-being. Water quality monitoring is integral to our infection control protocols. We have to stay informed. We have to implement best practices for water management and regularly monitor our water. And we can demonstrate our commitment to providing optimal care for our patients. It's great PR when you post, if you're on social media, and I'm sure many of you are, post that you are proactive in your infection control protocols. Patients love it. Let them know what you're doing to make sure that you're maintaining their safety when they come to your practice. When they don't think you are proactive in terms of prioritizing patient safety, they don't post very nice reviews. And if you go to social media sites like Yelp or Google and you search for 1-star reviews for dental practices, oftentimes you're going to see it's related to infection control. My dentist didn't wash their hands. The place looks dirty. So be proactive, right? The best defense is a good offense. Post, post, post. Okay, let's talk about sources. Sources of water contamination can be the water supply itself. I was telling you the raccoon story. So for practices that are using the municipal water supply, some may have filtration systems to take care of that water as it enters the building or enters their practice. Some may be using closed bottle systems or reservoir systems. Of course, the dental unit water line can be a source of water contamination. The water treatment system itself, backflow from the patient, and other cross connections, water storage, so reservoir or water bladder, dental equipment, and then environmental factors. So the primary water source entering the dental practice can contain contaminants, as we said, bacteria, viruses, fungi, chemicals, particulate matter. Public water is treated to meet safety standards. As we said, the EPA requirement is less than or equal to 500 colony-forming units per mil of heterotrophic bacteria. So dependent on also the aging infrastructure, as well as environmental pollution and other environmental factors. We said that dental unit water lines also deliver water to our dental instruments, devices, and they're prone to microbial contamination. And because we're talking about lines that are very small in diameter and they curve, and the water flows slowly through them and sometimes doesn't flow at all, you'll have stagnant water. That all leads to biofilm development. Biofilm likes the inside of these water lines as well. Biofilm needs to attach to something. So biofilm can harbor pathogens, release them into water. It can break off, increasing the risk of contamination during dental procedures. Water treatment systems, many may have water distillers, reverse osmosis units, chemical disinfection devices, filtration. All of those have to be monitored and regularly cared for, and you have to follow your manufacturer's instructions. And the problem that we have in dental practices is staff turnover. So anytime we have staff turnover and they're part of our infection control team, they're going to need to be trained on all of this, right? So systems require proper maintenance and monitoring, and failure can lead to contamination of our water, our source water. All right, cross connections, backflow here. Cross connections occur when your potable water, so again, that's drinkable water, from example, your dental equipment or utility sinks, inadvertently mixes with our drinking water. So non-potable, the stuff we don't want to drink, mixes with water that should be less than 500 CFUs per mil. And this happens due to backflow events caused by changes in the water pressure or improper plumbing, or at the source of the device itself, the patient source. Okay, so patients that were retracting with air water syringes, for example, all of those situations, hand pieces, when we're using them, create a vortex, which can cause backflow back into the handpiece. Hand pieces have to be autoclaved, and I might be getting a little ahead of myself here. Hand pieces cannot just be wiped off with Cava wipes. That includes your hygiene hand pieces. Why? Because you get biofilm within those hand pieces, just like we're talking about here in our water lines. So maybe you're treating your water and you're doing everything right, but you're connecting a contaminated handpiece, right? So hand pieces have to be autoclaved. They have to be maintained according to manufacturer's instructions. There are maybe a handful of hand pieces, electric hand pieces, that require different type of sterilization. Follow your manufacturer's instructions. But if you're a hygienist and you're given one Profi motor, you need to ask for more. You cannot you cannot barrier wrap and Sidex your Profi hand pieces and motors. All right, water storage here. So water storage containers, reservoirs, or bottle systems connected to dental units require maintenance. You need to follow the manufacturer's instructions. For some, that means emptying them, treating them at night, draining the system in the evenings, but you can still get biofilm them. You cannot stop there. Accumulated biofilm or residual water left standing for extended periods of time promotes microbial growth. So improper handling, storage practices can introduce contaminants into these containers. And once you get biofilm growing in a container, it seems like it will just come back. So you have to stay ahead of this. Now, and test. Dental equipment here. dental equipment connected to the water line. So I did get ahead of myself here. Hand pieces, air water syringes, ultrasonic scalers, water coolant systems require maintenance, including cleaning, disinfection, sterilization. And again, when we are not maintaining those, we are creating more situations for biofilm formation. And then, of course, environmental factors, temperature, humidity, ventilation can influence water quality and microbial growth. Way back when I was a dental assistant, it was considered just really high-tech equipment. If you had water line warmers, right, the water would be warm going into the patient's mouth. We don't want that anymore, of course, because that's just the perfect storm to grow biofilm, right? But that's something that was considered desirable at one point. All right, let's talk about regulation here. So there are many regulatory requirements and guidelines. These are just a few. Locally, you may have extra. You may have dental boards. Some dental boards have information in their state statute, especially around infection control. Others may not. We have some states that actually exceed the CDC requirements in their state statute. This is just a general overview. So we said the CDC advises dental practices to use water that meets the EPA's regulatory standards for drinking water, and that's less than or equal to 500 colony-forming units per mil of heterotrophic water. It recommends that any device that enters a patient's mouth, so hand pieces, ultrasonic scalers, air water syringes, should be connected to the water line and flushed for at least 20 seconds between patients. So we're going to go through that protocol here towards the end. But when you start your day, you should flush those water lines, every water line. And some recommendations are 20 to 30 seconds. I actually flushed mine for 2 to 3 minutes. And that has to do with my training. When I trained at UCSF School of Dentistry, and I see Dr. Nishimoto here, who's an alumni, it was during the AIDS epidemic. And so a lot of the guidance that you see here occurred out of that institution at that time. So we actually were trained at one point to flush water lines for 5 minutes between patients. And then it went to 2 minutes, and then eventually it went to 20 to 30 seconds. But at the beginning of the day, all of your water lines need to be flushed. Why? Because the water is stagnant, right? The water lines are curved. If you look at the units, those are areas where the water can stagnate as well. So you have to flush these water lines, but you can't depend on that as your sole treatment for your water lines. Okay, Environmental Protection Agency, the EPA regulatory standards of drinking water. Again, we stated was less than or equal to 500 CFUs per mil. And OSHA. So OSHA protects employees, right? And it mandates that dental employers provide a safe working environment for employees, which includes ensuring the safety of water used in dental procedures. And we refer to the bloodborne pathogen standard that requires employers to implement appropriate infection control measures to minimize the risk of exposure to bloodborne pathogens, which may include ensuring the quality of dental unit water. So when I present these various infection control courses, I always have folks that reach out about the what if scenarios. What if you had a boss, or what if you had leadership and they're telling you that you need to do this, but you know that's not correct, and I'm hearing in your class it's not correct. What should I do? And the one thing that you should start with, if you see a practice that's not compliant, you have a duty and obligation to report it, right? Go to your management first. If you don't believe that this is being taken care of in terms of your dental unit water lines, go to management, show them the facts. If they don't correct it, then you have a duty to report it. And usually that starts with your board. Why is that? Because we don't have anybody routinely inspecting dental practices. We don't have JCO like hospitals. Most states don't routinely go in and inspect dental practices. I think there's maybe 2 here in the entire United States. I used to have to go inspect dental practices as part of my job with the dental board here, right? I had my checklist. You don't want someone like me coming in later and then having an allegation filed, because it's not just the dental owner. It's everybody in there that knew it was going on and did nothing. When you relicense, you sign an affidavit that states you understand your state dental practice act, and you understand that if something is not correct, you're required to report it. You are the eyes and ears. And if you don't, you are subject to disciplinary action, just like everybody else in the practice. So keep that in mind. It's not always comfortable to have to report something. So do your due diligence. And if you see it, you have to say something. All right, American Dental Association, there's a link for you too, also provides guidance. Now, your state and local public health departments, the ASTDD is a good resource for you all. If you want to know what's going on in your particular state outside of your dental association, that's a good place to start as well. All right, so you can go to their website. They have great resources. Find out who your dental director is in your state and what resources they have for you. And of course, our ethical considerations, the Hippocratic Oath here, that we take promises to do no intentional harm to our patients. So again, if you see something, say something. You're required to. And of course, documentation. So it's very important that you document your maintenance and you document your tests. All right. Now, I always recommend, especially in infection control, that you have somebody in charge of maintaining, testing, like your autoclaves, the same, and documenting that. So whatever software system you're using, your practice management software, nearly all of them allow you to make a template, make one for your water line, maintenance, testing, etc. Have somebody in charge of that so that when they perform it, they're going to date it. Maybe it's going to be on a spreadsheet and they sign off on it. And then the dentist owner should be reviewing that and signing off on it as well, right? So that's a very good way to keep track of all of it. That way, if somebody like me came in and you had a complaint filed, and usually the complaints follow disgruntled employees because many of your patients aren't going to be aware if you're doing what you're supposed to be doing or not. I'm going to look at your logs first. And if you're not keeping good records, then I'm going to start looking a little deeper at everything else, right? Okay, let's talk now about testing. More about testing. All right, so this is from the ADA, but maintaining and monitoring our dental unit water lines require a few things in order here. Of course, we're going to use EPA regulatory standards for drinking water. Consult with your manufacturer for what's required. Most of the time now, you can go right to your phone and pull up any instruction. So if you are new somewhere and they can't provide you with the IFU, look it up online. Follow recommendations for monitoring water quality, again, provided by your manufacturer. Use sterile saline or sterile water as a coolant irrigant for surgical procedures. You cannot use water out of your dental unit water line. And we're going to repeat that. You're going to use a delivery method also that is sterile. So either a sterile autoclavable device or sterile disposable and dispose of it appropriately. You can consider irrigating with a sterile and or antimicrobial solution during all non-surgical pulpal therapy or endodontic procedures, and provide staff training on how to properly maintain and monitor dental water quality. Okay, so when we talk about dental unit waterline maintenance, we're going to be talking about testing, shocking, treating, and maintaining. And testing is the only definitive way you are going to know that your dental unit waterline maintenance protocol is effective, it's doing what it's supposed to do, and that your water lines are safe. Now, you know when you're using an autoclave and you are spore testing, if you are sending your results out the strips, you have to wait for that lab to report the results. You can go online now and look them up. That can take a few days, but you all probably are still putting your instruments out to service, whether or not you know that the autoclave is functioning properly, right? The same thing with your water lines. So you have options here. In office, you can provide within the operatory yourself. You can check your results yourself almost immediately or within the incubation time, okay? And it's recommended that you perform quarterly or more, but always start with checking with your manufacturer what they recommend. Always start baseline. So if you haven't maintained any of your water lines, and there may be some of you that aren't, it's a good thing you're here. You want to start your protocol, or before you introduce anything else, by running a baseline test. Okay, see where you're at. Then routine testing. So again, find out your manufacturer's recommendations. Do they recommend monthly, quarterly? Check the recommendations. Now, OSAP's recommendations monthly until you achieve 2 consecutive pass tests. Then you may consider going quarterly. Test always before you shock your lines and after every fail test. When I think of shocking the biofilm. Okay, we're trying to rattle it, get it to go away. So high-level disinfectant is shocking disinfectant, used to remove the biofilm in the lines. And biofilm, again, is very difficult to remove. Shock before the initial use of any dental unit waterline treatment product. Shock quarterly at a minimum. And shock when the test reveals contamination less than 200 colony-forming units per mil. Now, we said that the EPA requirements are 500. But we want to get ahead of this because biofilm develops very quickly. If we wait to work 500, we're too late. The water lines are probably already contaminated, okay? You can treat with various products here, and these are just examples. We're concentrating on testing this evening, but many of you may be using the straws, the tablets, liquid. Follow the manufacturer's IFUs, and yes, you still have to test even though you're treating the water lines. Because again, you need to make sure that what you're doing is effective. How do you know your water lines are safe? You can be doing everything you need to do and you can still have a failed test. And that's how biofilm works. So all protocols may still lead to failed tests. Doesn't mean you're a failure. It means that biofilm won, right? So you can be doing it all correctly, still have failed test results. So that's why it's important to test regularly. And that's why it's important to test where you're going to get your results quickly. Because if you had a failed test and you're waiting for a laboratory to send those results back to you, you're using water that's potentially contaminated, right? All right, Flushing, we said 20 to 30 seconds at the start of your day for every water line and 20 to 30 seconds between every patient. And 20 to 30 seconds is a long time. So I always had timers in my operatories for my employees, so you could tell what kind of employer I was. I was a stickler. Surgical procedures here. Again, always use sterile water, sterile irrigant, sterile saline delivered from sterile devices, whether they are autoclaved or disposable. All right, any questions? And again, there are a few hundred of you that logged in, and I just want to make sure that you have your handouts because you're going to be lost when it comes to taking the quiz. So make sure you have it. Tap on the red banner at the top of the screen. I'm going to be bringing April on here in a minute. Let's go ahead and see what the questions are. Any relationship between the age of dental equipment and water lines and biofilm? So I can tell you here, Dr. Nishimoto, in Maricopa County, we had a case while I was the chief here of used equipment that was sold to a clinic where they also noted they had some patients that developed hepatitis C, but it turned out it was not a relationship. They were concerned that it was the used equipment. So if you're buying refurbished equipment, depending on the age, you have to understand what they're doing to make sure that refurbished means, are they, refurbishing all the lines and so forth. So most certainly, if you're inheriting a dental practice, find out what the protocols have been. I would change out my water lines. They're easy to do, and at least you can start fresh. But new water lines don't necessarily mean that you're not going to collect biofilm for a while and you get a pass, because biofilm will be created in just a few days. Yep, closed bottle system should be emptied daily at the end of the day and dried out to reduce biofilms, but you can't depend on that only. You still have to use your disinfectant products. So to confirm, this is from Maggie, even in a self-contained ultrasonic unit filled with bottled water, a microbic biofilm forms between the self-contained water bottle and the line ending at the handpiece. It could. Why is that? You can get backflow, right? And make sure that you're following the manufacturer's instructions for the ultrasonic handpiece portion, because many of you ask questions during infection control. Are we supposed to be autoclaving these? And it turns out for some of those manufacturers, you are. So if you're being told to cava wipe those and they should be autoclaved, why? Because internally they could have biofilm. Do I prefer any particular kind? No. I start with manufacturer's instructions. Whatever you use, follow manufacturer's instructions. At the end of the day, what I mean is after everything you do, you have to test. You don't have X-ray vision, you don't have microscopic vision, you can't see the biofilm growing in those lines, so you have to test. Good questions. So if you have a fail after a shock, what do? Throw away the water lines and start over, get new bottles. If you have a fail after a shock, and sometimes you will, first of all, contact your manufacturer. Sometimes you have to repeat it, you have to treat it. Contact your manufacturer, and you will. Again, biofilm is evil. Maybe not possible, but it happens. It's a good question. Is there a handpiece that I recommend? Nope. Are sterilizable water lines in our future? Well, you could have sterilizable water lines, Marie, and that's a good point, but you also have backflow that you have to deal with, right? So it's a constant battle, right? And that's why I'm saying you could do everything you need to do and still have a failed test. That's why it's important, and you'll hear April talk here momentarily about how you can do an in-office test. It's easy to use. Any staff member can use it, and you're going to get immediate valid results so that you know everything is safe to use and that what you're using, your protocols are effective. What's the best cleaner for water lines as units are sensitive to harsh chemicals like bleach? Again, check with your manufacturer for your particular unit. Advise regarding Cavitron unit that failed when water was tested, but water does not come from the bottle. So where did the water come from? If you could go ahead and put that in for Tiffany. Christina, the CE credit info is the third slide in my handout. And why don't we just have clear water lines for clean water going to the handpiece? Because even if we had clear water lines, it's not going to tell us the water quality, if I understood your question. If you fail in one op, does the whole office fail or just that op then shut down? So if you're using a bottle system and they're individual, then it would be just that water line, right? If you're using a system that, a source system that attaches at the level of the clinic or your office, then that's a different matter. Then you're going to have to contact your manufacturer and likely shock all the lines. Self-contained bottle systems, some of the office use tap water with ionizing tab, other use distilled with ionizing tab. Thoughts? Well, again, at the end of all of it, testing's required. Tap water, there's hypochlorous acid, which is getting off track here, that can be used and is used in some of these, but you have to test. Again, and it's not specific to one necessarily product, and that's my point. So you can be doing all of these things and still fail a test. Testing has to be part of your protocol and it has to be done regularly. I don't have any studies on ozone treated water yet. There are studies out there, and I'm watching very carefully, and I'm in communication with one of their researchers. My ultrasonic unit is hooked up to the building's water line and not the bottle. Does the building have to check their water? You have to check the water, Yolanda. Okay. Maria, I see handpieces and air water syringes with attached lines being sterilized between patients. Somebody's using the silver tablet with reverse osmosis water. We generate, but we don't drain bottles daily. Interesting, the RO systems, you still have to make sure those are operating and functioning, you know, even in households. So I am going to go ahead now and bring up April's presentation because she has great information for you here. And in your course folder, you're going to see more information as well. So let me go ahead and have April log in, and George as well. I'm going to go ahead and introduce April. So everyone, I am really honored to introduce you all to April Smith. April has 25 years experience as an educator in the dental industry, and her career reflects on expansive range, including clinician, educator, consultant, mentor. As a dental infection prevention specialist with ExactBlue Technologies, Inc., she has provided training for dental public health units, hospital clinics, the Canadian military, study clubs, distributor territory managers, and dental association membership groups. Her no-nonsense, clear and concise delivery is well respected by dentists, denturists, hygienists, and dental assistants across Canada. Feedback from her lectures confirms her ability to coach and guide clients through new learning experiences, and her passion and enthusiasm for the dental industry is constantly being fueled by her ambition to always provide the most current and relevant information to her clients. We are really excited to have you here, April, and I want to remind everybody that at the top of the screen we'll be posting the link where they can learn more about your technology. Thank you so much.
Well, thank you. And thank you for the opportunity to meet with you this evening. Again, as the doctor said, my name is April Smith and I work with ExactBlue Technologies. And I am coming to you this evening from lovely Niagara in Ontario. This is a Canadian-based company. And I have some really exciting information to share with you this evening. And we're going to start right off the top with a really quick video to get everybody all connected and eager to learn more. I'm just going to put my microphone on mute and we're going to start that video right now. Excellent. Well, that was a lot of information in a very short little video clip. So we're going to dig into it a little bit more over the next couple of minutes. So I hope that you'll join me for that. So we're going to get right into it here with a little bit of information about ExactBlue in particular. And I just want to let everybody know that we are unique in the fact that water testing is the only thing that we do. And we don't only work in the healthcare setting, we work across several industries. So we are, for example, involved in testing of municipal water sources, cooling towers. We're involved in agriculture, hotel, recreational settings like pools, and also in lakes and wells, because water quality is extremely important, not just in healthcare, but in all those other industries as well. We develop the technology ourselves and we manufacture ourselves as well. So really important to note that this is all we do. We are water specialists and it is a water test designed this evening. The one we're going to talk about very specifically is developed for dentists and dental practices. So we have a test that is designed specifically for the bacteria that is of concern to us in our industry. As we know, there's millions of different types of bacteria on planet Earth. We're not looking to identify all of them. We want to focus on the ones that are of specific concern to us in dentistry. It is also important to note that this particular test we're going to talk about tonight, you'll see the name of it on the bottom left-hand side of your screen there. It is called the AquaVial Quick Check test. And this particular test is going to be compatible with all your waterline cleaners, and that's not always the case with some other tests that might get interference from some of the other chemicals you use. That will not be a concern for you with this particular test. Now, there are some very specific features to this test that are going to be very helpful for us in our industry. And the three are listed on your screen here are the fact that it is very fast, it is very easy to use, and it is highly accurate, as you saw how quick it is in that very short video clip that we watched. So we're going to start with that element of efficiency and being expeditious. We're all busy, right? We all know that time is money, money is time, and we're already pretty busy. So if we're going to integrate a new policy and procedure within our practice, it needs to be something that is going to be very quick. Now, this is the fastest test in dentistry. You're going to get results in 30 minutes. All right. This is using the newest technology that we have available to us. And you'll see on the right-hand side of your screen there that not only are you going to get results in 30 minutes, but there's no equipment, meaning that you're certainly going to have some cost savings, but you don't need to purchase an incubator, right? So you're not going to have to buy an incubator. You're not going to have to find a place to put the incubator in your office. You're not going to worry about maintenance of another piece of equipment. We're going to incubate at room temperature for 30 minutes. And that kind of makes sense, right? Because you have that equivalency. We know that the bacteria is growing in your water lines at room temperature. So this is a test that is also going to be done at room temperature. Now, if you have your eyes just slide down to the bottom of that screen there, you'll see a little chart and you'll see titles there in blue and in pink. And what we're doing here is we're just doing a little comparison between lab or mail-in tests and in-office tests. So when we're talking about our lab or mail-in tests, we've got several options there. So we've got our HPC lab tests, our heterotrophic plate count type of test. And as we move towards the right-hand side of the screen there, you've got things like your flow cytometry tests, your qPCR tests. And then when we move into that pink section there, you've got your in-office tests. Right now, I think we've all seen the paddle test, kind of like a dip slide type of thing. And then in the middle there, you've got your enzyme-based test. And then on the right-hand side there, we've got our AquaVial Quick Check. And then take a look at the next row down where we're looking at how quickly we can get results in some of the things, in some of these different tests. So you'll see that for a lot of the HPC, the lab tests, they take quite a long time. As the doctor mentioned in the presentation earlier, you're looking at days, potentially weeks to get those results. That is far, far, far too long for us to wait to get confirmation that the water we're providing to our clients is safe for human consumption. And again, as our eyes travel to the right-hand side of the screen, we get that confirmation right at the end there under the quick check test that you have the potential to select the fastest water test available to you at this time, which is, again, 30 minutes. Now, the value of being quick, right? I mean, certainly I think we all can understand the value of that. The quick turnaround means that if you do have a problem, we can initiate an action plan to have corrective action be done quite quickly. If you're waiting for 2 weeks to get your results, and then your results indicate that you are in excess of your 500 colony forming units, and you need to shock and retest, and then wait another 2 weeks. I mean, certainly this could be drawn out for quite some time. And we certainly don't want to get into a situation where we're looking at costly downtimes, potential closures of some of your operatories. So we want that reduction in liability, and we certainly want to have that protection of ourselves, our colleagues, and our clients. Now, this is a very easy to use system. This is a color-coded system. And so if you put your eyes on the left-hand side of the screen there, you'll see a little slide there. You'll see a little circle. It is pink with a little check mark in it. So that is going to indicate that we have clean water. When you order the test, the fluid in the vial will be pink. So we want to start pink and we want to finish pink. If your sample turns a purple color, which is the next one, moving your eyes to the middle of that slide there, that would indicate that you have some contamination and you are above your 500 CFUs, and you would then activate your action plan. Typically, that would be a shock treatment. And then sliding your eyes a little bit further over, if your sample turns completely clear, that indicates highly contaminated water, and you could potentially be in excess of 2,000 colony forming units. Now, in the middle of your screen there, you can see the 3 vials with the red caps. And you can see the color code system there. To the left is the pink, in the middle is the purple, and to the right is the clear. So this really gives your team the ability to read these results very quickly and easily. I mentioned on the last couple of slides there, potentially you may have seen the dip slide type of test where you're counting colonies. That can be very labor intensive and certainly prone to operator error. But again, when we slide to the bottom of the screen there, we've got that same type of chart where we're comparing the lab and mail-in tests to the in-office tests. And certainly some of them are providing a colony forming unit measurement. Some of them have instrument cell counting, molecular diagnostic methods, counting those colonies, and then the visual color change. So this is a very quick and accurate and easy to use test. Now, the doctor mentioned in her presentation how important it is to have that accountability. So not only is it important to do the test, but we need to have a record, right? We need to have some sort of logging system to be able to, keep track of the information. It's all fine and well to do the test, but if we're not tracking it and able to provide that information in the event that there ever was a question, you're kind of missing a key element of the program. So we have developed something that we refer to as the Hub. This is an online tool for your ability to schedule your tests and record your results. Everything stays together. It puts you in compliance for being able to keep track of those results for years. So it's very, very convenient. You can access it at any time on your smartphone or your desktop. You certainly could do it in a paper format. We do have paper logs as well, but this is just a really quick and easy and very reliable way to record your results and your scheduling. As the doctor mentioned, you might be doing it monthly, you might be doing it quarterly. So it is really important to make sure that we put our water testing schedule together and that we stick to it because, again, we're busy, right? So the last thing you want is to get into a situation where you get a couple of months down the road and you think, oh, shoot, we were supposed to do it this month and we totally forgot. So now what do we do? Do we do it 3 months from now or 2 months from now? And now your paperwork and your logs are all out of whack. So really important to get that schedule nailed down and make sure that it is communicated to all the staff so you have that ongoing consistency. All right. Now, highly accurate. Okay. This is the newest technology that is available to us. This is going to be utilizing a functionalized gold nanoparticle. This is what we refer to as rapid cell wall recognition technology. All right, so let's hit that again. Rapid, it's very fast. Cell wall recognition technology. So let's take a quick look at this here. If you put your eyes in the top right-hand corner of the screen there, again, there's that pink fluid. We said before that it's going to come to you pink and we want it to stay pink. So it's the nanoparticles that are part of that fluid that give us the ability to determine the concentration of bacteria. So in that pink vial there in the top right-hand corner of your screen, you'll see it is pink. There's only nanoparticles present. There is no contamination, and that's your goal. That's what you want. Now, As your eyes go down to the bottom left-hand side of the screen there, you'll see that purple vial there. So you've got an aggregation of both nanoparticles and bacterial cells. You can see that it's attaching to and identifying that cell wall. And then as we go to the bottom right-hand side of the screen there, you'll see it's completely clear, right? We've got highly contaminated water. Now, I'll be the first one to admit that I'm not a scientist. We do have the founder of the company with us tonight, George Batos. He's your science guy. So if you are interested in doing a deeper dive into gold nanoparticles, he's your guy, and I'll give you contact information at the end of the presentation. But if you're interested in all of that, then certainly we can make that happen so you can do a deeper dive into the science of gold nanoparticles. But for those of us who aren't the science geeky type people, we do have a quick video here that I think when you watch this video, you'll be able to just get a good gist of it. So I'm just going to put myself on mute again. It's a 60-second video. Take a look. There we go. So hopefully that was a little helpful in just kind of nailing down that whole concept there. But again, anybody who's looking to do a deeper dive into that, you only need to say the word, because I know George loves talking about this. So moving on from there, this is where we kind of get into a little bit more detail here on the difference between culturing methods and that nanotechnology that we were just talking about. So this kind of backs up what was being shown visually in that video. So if we look at the left-hand side of the screen there under culturing methods, you'll see that these culturing tests, they really try to attract and feed bacteria until they're able to get large enough for us to identify it with our eyes and count those colonies. You know, there is definitely a challenge with this because not all bacteria is attracted to, you know, certain types of food sources, and not all bacteria grows at the same rate. Some will be more sensitive and grow faster, and some not so much. So this certainly does present a potential issue for underestimated colony counts, where by comparison on the right-hand side of the screen, again, we're talking about the newest technology that we have available to us, that nanoparticle quick check test. It really acts more like an antibody, right? They're not going to wait for the bacteria to be attracted to them. Instead, they're actively going to search out those bacterial cells. So once the bacteria has been detected, the nanoparticles are going to attach themselves to the bacterial cells, which gives you a far more accurate test result. And let's be honest, if we're going to spend the time to do this, we really want the most accurate results possible. We've got lots of science, lots of labs that we do, lots of white papers and research. Again, this is something that we can provide to you. I'm not going to get too into the details here. I'm sure everybody's starting to feel the end of the day coming. But as you can see here in this chart, you know, I know there's a lot of numbers there, so don't panic, but the end result here is that the quick check test results were very consistent with the results obtained through the lab testing method. Big difference, of course, the lab test can take, you know, a week to 2 weeks, where this test is going to take 30 minutes. So big difference there. We've got lots of case studies, lots of science. This is one that we did specific to cavitrons. I know that there was several questions in the chat board specific to your ultrasonic and your cavitron units. In this particular case study, we found 152 different species of bacteria. Cavitrons are notorious for having too much bacteria in them because the water just flows through them so slowly. The water's going so slowly, in essence, that it's just kind of rolling over top of the bacteria. It doesn't have the power and the volume and the velocity to break it up and flush it down through the lines. So it is really important, especially with those ultrasonic units, to make sure that you are following those manufacturer's instructions for testing, shocking, and maintenance, because they are a bit of a challenge. So yeah, definitely. If you need case studies, you need more information, you need only to say the word, and we can certainly supply those for you. Lots of case study findings. So if you look at that first bullet point there, we're talking about that HPC method, that heterotrophic plate count. That's your lab method. Those methods that use higher temperatures and shorter growth times tend to only detect rapidly growing culturable bacteria, whereas lower temperatures and longer incubation time is going to detect slower growing bacteria. That kind of makes sense. Again, results are showing that current standards for microbial testing are not an exact science. And that's why we always want to make sure that, as healthcare professionals, we're always gravitating towards the most current and reliable science. Results we find depend on several different factors. We've found this out through numerous studies. So things like the type of media that we're using in the test, the incubation temperature, the incubation time, the presence of biocides, we talked about that earlier, and waterborne nutrients can all have an effect on the type of test and the results. So the HPC test methodology has a tendency to not only underestimate that true cell count. Again, we're talking about the lab test, but this is all about, when we're doing the test right at the sampling point, right? Because we have to take into consideration that if we're going to ship it to a lab, there is going to be a delay in the actual test occurring, right? So the longer it takes for the test to actually occur, there's a challenge with stabilizing that sample. I mean, a lot of the labs are really backed up to the moon and beyond right now. So testing right at the sampling point is going to give you the most accurate results, as opposed to potentially having your sample be compromised by the additional growth of more bacteria, or perhaps some of the bacteria die off in that transportation time. So something to keep in mind as well. So lots of different factors involved here. However, the bottom line is it's all about identifying that bacteria that is specific to us, concern to us in dentistry. On your screen right now are the microorganisms that we are specifically looking for. There's 12 of them there. So that is what we will be focusing on with this test, because those are the ones that are of greatest concern to us. In your presentation earlier this evening, there was a great conversation about Legionella, non-tuberculosis mycobacterium. Aspergillus is another challenge for us in our industry. Legionella, for example, is a very slow-growing bacteria, and it requires a very specific media in order to grow it. So if you are sending your sample to the lab, you would need to be very specific in your request to get the growth of Legionella recorded in your sample. And non-tuberculosis mycobacterium is something that was discussed in your training session prior to this. And it, again, requires very specific media. So things to take into account when we're looking at the science and the microorganisms that we're looking to identify in the testing methods. So again, we started our presentation with a very quick video on how to use the test, and we're going to wrap up our presentation with, again, a little quick summary of how to use the test. So, step one is to collect your sample. So you're going to take your water source, your air water syringe, your high-speed handpiece, your ultrasonic unit, whatever it may be. You're going to flush it for 20 to 30 seconds or longer if you can. The more flushing, the better. And then you're going to fill up your cup, right? And as you can see in the image here in the top left-hand corner of your screen here under number 1, you're going to have your syringe that comes in the kit. And then there is a filter stick, which you're going to attach to the syringe. And then number 2 is you're going to pull your water sample through the filter. You're going to catch the bacteria in that filter stick. And then we're going to wash the sample and remove any potential contaminants that may be there. And then we're going to add that sample after we flush it 3 times. You're going to add that to the testing vial and then incubate for 30 minutes at room temperature. So again, no equipment involved. It's very quick. It's very easy. Any member of your team would be able to do this very quickly and easily. And then, of course, you're going to record your results for accountability purposes. So this is where we wrap up our presentation here. I'm just doing a quick time check here. I have, 9:30 on my clock. I'm 3 hours ahead of you. So we are right on the dot on time. There's my contact information on the screen there. You can see my email address. And we also have a QR code there for you as well if you'd like to take advantage of any of the offers that we have available to you. You'll see there's a promo there at the top of your screen. And that QR code will take you to our website so you can get some additional information if you need. But please feel free to reach out if you have questions or you'd like to do a deeper dive into the science on nanoparticles, or if you have any questions in general about water quality testing or the AquaLab Quick Check test. And I think at this point in time, I'm just going to throw it back to the doctor.
Thank you, April. Excellent. We have a couple of questions for you here. This one is from Dr. Najarian. April, is there a need to test for volatile organic compounds, i.e. plastics? If so, how do you test for these?
Yeah, so we're looking at more of a bacterial contaminant here. We're looking to make sure that we're staying in compliance with the guidance that we're given, that we want to make sure that our water that we're supplying is less than 500 colony forming units of bacteria per milliliter of water. So the focus here will be on bacterial counts as opposed to plastics.
Do you have to check water from each line at the unit or just air water?
Okay, so that's a great question. So you're going to want, for most accurate results, you're going to want to check each water source. So you might have, for example, in your office, you might have 2 air water syringes, 1 high-speed handpiece, and an ultrasonic. So that's 4 different water lines. So you would do a test on each one. So you would need 4 tests. So what we want to do there is we want to get the most accurate results possible. So here's the challenge. So let's say, for example, you have 2 air water syringes, right, in your practice. You've got one on the assistant side and you got one on the doctor's side. The one on the assistant side is used a lot. It is continually being used all day, every day, multiple times on every single patient. So it is being flushed out on a regular basis, where by contrast, the one on the doctor side is not being used anywhere near as often. So it will have a higher level of stagnation. So you could have 2 water sources in one operatory, and both of those have different levels of bacteria in them. They're not going, each water line will have a different level of bacteria in it. So if you want your most accurate results, you would want to test each line separately. We really want to get away from what we refer to as community water testing. Community water testing is when you take a Dixie cup and you take a squirt from this one and a squirt from this one and a squirt from this one and you test it. The challenge, of course, is that if it passes, how do you know that it's a true pass? Because you've diluted your sample from a variety of different sources. Or even worse, if it fails, now it's more expensive and more time consuming for you, because now you have to shock and retest all of them when potentially it may have only been one water line that threw you over that 500 CFUs.
Another question here. What is the in-office test schedule, and is the quarterly test schedule sent to a lab?
You can send your, if you're using a lab and you want to ship to a lab, that's the frequency of that is entirely up to you. you know, as you mentioned in your presentation, doctor, you would want to follow your regulatory guidance, or if you're following OSAP or whatever it happens to be. The only thing that I can advise is that if you do have a stubborn water line and you just can't seem to get it to pass, that would justify a little bit more frequent testing, because for whatever reason, it seems to be a little more challenging. Perhaps it has a higher level of stagnation. Perhaps it's, you know, maybe it's exposed to heat. It's one of those units that's sitting in front of one of your lovely big windows on a summer day, and it's you know, growing a little bit more bacteria exponentially than perhaps other units. But if you have one of those stubborn lines and you can't seem to get it to pass on a regular basis, you might want to increase your frequency of testing for that particular unit.
Or for units that you may not be using as often as well, right?
Yeah. Yes, frequency of use and the level of stagnation would certainly come into play. Absolutely.
Okay. I want to remind everybody too, at the top of the screen, also we have a call to action banner, and you can go and learn more by tapping on that. Everyone does have a copy of April's presentation in their handout. I would recommend, if you do go to the call to action banner, if it's information you're going to take back tomorrow to your practices, which I hope you do, bookmark it. You can save it to your device and take it back to your practice and tell them you've learned about testing that you can get done here in 30 minutes and you know right away, because that's the only way you know if everything's working correctly. Anything you want to say in closing, April, before we tell everybody good night?
No, you know what? I would just like to thank you for the opportunity. It was a pleasure meeting you and everyone this evening. I hope this information that we provided tonight was helpful. And again, grateful for the opportunity. Thank you so much.
Thank you for being here, and thank you to ExactBlue Technologies for supporting this program. We'll go ahead now. We will close out and send everybody off to their quiz. Please reach out to April if you do have questions, and through the URL to find out more about their product. Thanks so much, everyone. Good night.